Hello. Hello, Prajakta ma'am.
Yes, Dr. Neha.
Should I start or should we wait for some few seconds?
We will wait for 5 minutes.
Okay, okay.
Good evening, ma'am. Shall we start with the webinar?
Yes, Prajakta, we can start now.
Yeah. Over to Dr. Neha. You can start the webinar.
Yes, thank you, ma'am. Namaste and a warm welcome to all the dignitaries and delegates to webinar number 90, organized by NEMA OBGY Society Central. Today's topic for webinar is hypothyroidism in infertility and pregnancy by our eminent speaker, Dr. Sanjay Kadlimatti sir. Myself, Dr. Neha Jaiswal, today's coordinator for this session. I would like to introduce Sir Dr. Sanjay Kadlimatti sir. He has completed his BMS from SVM Ayurvedic Medical College, Karnataka. He has done post-graduation in Kaya Chikitsa from Ayurveda Mahavidyalaya, Hubli, Karnataka. He has done a post-graduation diploma in yoga and naturopathy from Maharshi Patanjali Institute of Yoga and Naturopathy Education and Research, Gujarat Ayurveda University, Jamnagar, Gujarat. He has completed his Ph.D. in 2010 from Institute of Postgraduate Teaching and Research in Ayurveda, Gujarat Ayurveda University, Jamnagar, Gujarat. It was the first PhD research thesis in Ayurveda on the topic osteoporosis. He has an academic experience of 18 years where he has been a lecturer, associate professor, reader, professor, principal, and at different reputed institutes. He has achieved second rank with silver medal in final year BMS exams. First prize for best paper presentation in November 2005. Best paper presentation in Panchakarma session in June 2009. Best paper presentation in valuable and personal contribution to the development of Ayurveda in June 2009. He is a visiting faculty at Vedika Gurukul, Emeryville, California, USA. He has also received Great Teacher Award by students of Vedika Gurukul, Emeryville, California, USA. Received Foundation Day Award from BLDE Association on 23rd October 2020 for excellent service during COVID-19 pandemic in preparation of Ayush recommended immune booster in Ayurveda for COVID warriors. Received Seva Sant Award for his services from Bharat Yuva Vedic Charitable Foundation, Vijayapur in 2021. He has received Best Teacher Award, that is Adhyapak Bhushan 2024-25. He has 25 publications in peer-reviewed index journal. He has attended 124 conferences as a resource person and as a guest speaker. He has conducted 9 television and radio programs. He is an expert panel member for an IMR project entitled Clinical Incenses Study for Developing the Standard Operating Procedures and Practical Guidelines for Virechan, conducted by National Ayurveda Research Institute for Panchakarma, Kerala, sanctioned by CCRS, Ministry of Ayush, Government of India. He is member of Institutional Ethics Committee at Vijayapur since June 2018. He's a referee for AYU International Journal for Yoga and Journal for Ayurveda and Integrative Medicine. He is PG and PhD examiner for reputed Ayurveda universities. Now I shall request Sir to start his lecture.
Good evening, everybody. Hope I'm audible and my slides are visible.
Yes, sir.
Yes, sir.
Welcome to Mahavidyalaya platform, sir.
Thank you, ma'am. Thank you very much. It's my pleasure to join. So good evening, all. Let me first only take this opportunity to thank Nimao B.G.Y. Central for considering me, because I consider myself as an accidental gynecologist, because I'm a chikitsa person, and by accidentally just following the principles of Charak Samhita, when we treated certain cases of PCOD and some hypothyroid disorders, tubal blockage, etc., we gradually got success, and it happens in Ayurveda that in mouth to mouth propaganda happens, and people tell their success stories to their relatives, and then people start coming. So since last 5 6 years, I am more of a gynecologist than the Kaya expert in Ayurveda. So thank God and thank Dhanvantari for and thanks to Charak Samhita for giving me the thoughtfulness, and also my gurus in Jamnagar. So the topic given today is hypothyroidism and infertility and pregnancy. Without wasting much time, we'll start the presentation. So this infertility is a major challenge for all of us. We know that, because the incidence is rising very significantly, and recent studies, when I checked online before presentation 2 3 days ago, it says 10 to 14%, and even some studies suggest that it is more than 20% also population in their reproductive age are affected with infertility. The most common cause is obviously we all know in urban areas. The time has changed since compared to last 30 40 years, that young ladies are very much determined, and they want to be independent, and they want to be free, and they want to be working as well as. So this type of career reasons, that becoming self-reliant and all. So gone are the days that girls used to get married earlier in their highly productive reproductive age. And again, when it's not just the reason of career reasons, but once you join the career, there are more of challenges that urban women face. That it may be work pressure, or some other targets, some family issues, something. So if you compare this last 3 decades, the age of marriage is getting 25 plus as compared to the 3 decades ago. Obviously, we can see that in hypothyroidism and infertility, diet plays a very important role, and it is one of the Trayopastamba and the first Upastamba of Ayurveda, Ahara, Nidra, and Brahmacharya. Lifestyle factors and environmental stresses are also the major causes. Junk food. Most of the urban people are habituated to this. The cooking has been reduced. Ordering online, eating junk food, which is having more sort of stuff which will destroy or derange our hormonal system, including digestion, and makes you obese. More of abaddamedas, what we can call from Charak Samhita's Prameha Chikitsa. So this type of glucose intolerance, obesity, more of lipid disorders, etc., will lead to complete derangement of the physiology of reproductive system in women. The same condition in men also, but today's topic is in women infertility. That's why I'm talking about this. And obviously, compared to last 3 4 decades, alcohol consumption among women has been increased, especially in the urban areas. These are the major disrupting issues related to hypothyroidism as well as ovulation issues. Key medical reasons nowadays, when we study, there are lots of studies which says that the most common cause of infertility in women is PCOS. Then comes obesity, thyroid infection, diabetes and glucose intolerance, pelvic inflammatory diseases, and obviously tubal blockages, which are majorly because of tuberculosis related. So all these are the major challenges that we face in the clinical practice in our day-to-day OPD. One or the other cause will be seen when we assess the patients of infertility. So high costs, why people don't go for treatment early? Because in the contemporary science, they try all the measures, including ovulation inducers and treatment for PIDs, and they go for treatment of tubal blockage, etc. When everything fails, they go for assisted pregnancy like IVF and all, which is very much costly. And also, we know in India that always there is a social pressure, uh, but not now in urban areas, but in rural areas, in olden traditional Indian families, always women were blamed for not conceiving. Maybe it was a male dominant society then, and they always used to blame the women. And because if they speak out, it was considered as a social stigma. That is why these two causes, that is the cost effect as well as the social stigma, are the major two reasons for the delay in approaching the treatment. They think that we will get all right, or if I speak out about this, it will be a social stigma like that. That's why it is some of the one of the neglected reason for the reproductive health issue. So stigma, as I said, always blamed on women, which is wrong. I have seen in my clinical practice that I tell them that both couples should come, and when we see, I have three cases where there was azoospermia, and always the family was blaming the women who was always normal. So the cause of azoospermia in two cases was varicocele, and one case it was necrotizing testis, maybe because of some reasons we don't understand, because the patient did not agree for the testicular biopsy. So this is obviously the social stigma where, unfortunately, even though husband is having some problems, but still women are blamed in some Indian traditional families. Not learned people will not do this. So employment data says that working women might experience higher infertility rates, often linked to elevated stress and delayed childbearing age. So we don't say that if I say that the working women should concentrate not on the working issues and families, because this is a NEMA OBGYN platform, national platform, and I'll be considered as one of the anti-feminists, but still looking into the future of Indian reproductive health of women, we should follow a fertile age to be getting married, and there are still days left in your life to concentrate on opportunities, careers, and other things. But I think people will realize this as we go on in future, that looking into the family and healthy childbearing, we have to consider that getting married in a very healthy, fertile age is the best solution for this type of issues, where we will find difficult to conceive after 25 or 30. And even if we conceive also with assisted pregnancy, all assisted measures, we don't usually get a healthy child, which is very unfortunate for the family in future. So thyroid disorders, coming to my point, we all know that either thyroid produces too much or too little. There are the only two possibilities, where too less and too more is hypo and hyperthyroidism both, and confirmation is done by the thyroid profile test. These are the normal values. We all know that. So let's not waste time in this. If, but one thing, there is clinically established and pseudotype, like, there is T3, T4 are normal, but still TSH is high. That means the thyroid is mocking thyroid normalcy, but TSH is high. It is called a subclinical thyroid. And sometimes established thyroids will have T3, T4 excess. I mean, T3, T4 is reduced and TSH is high. So two considerations, subclinical and clinical. So if these two conditions are there, let us see in the further slides that how hypothyroidism influences infertility as well as pregnancy, and what is the Ayurvedic understanding of this probably, and then what best we can do to manage these two conditions in hypothyroid lady. Nowadays, this condition is also called as underactive thyroid, and it happens when the thyroid gland doesn't make enough of thyroid hormone. It's all known, and it may not be noticeable in the early stage because most of them are asymptomatic. It such happens that most of the people say that it's very healthy to be obese, overweight. Common word used in our society is खाते पीते घर के लोग हैं, तो थोड़ा healthy रहते हैं. Actually थोड़ा healthy should not be too much obese also, but still, even though there is obesity, people will not give concentration, or they will not give that required attention to consider about, to check about the fertility issues. So that is why, as the condition is very asymptomatic in the earlier stage, it goes unnoticed until it is clinically established. But over time, when this becomes an issue after marriage, 3, 4 years of unprotected sex, also they will not conceive. Then they will approach the doctors, and unfortunately, at that time, it is established hypothyroidism. And if it is not treated properly, it will have some obesity issues, cholesterol, and heart problems, etc. Symptoms, once this onset happens in the severe conditions, we see two most common early symptoms, that is fatigue and weight gain. A person feels tired easily, and there will be weight gain also, gradual weight gain. So if this is misunderstood as being healthy, or I'm getting like little bit of overweight because of my eating habits and sedentary lifestyle, and if they don't approach, then these are the most common symptoms of hypothyroidism, that is weight gain, puffy face, hoarse voice, tiredness or lethargy, sensitivity to cold, constipation, dry skin, coarse hair and skin, muscular weakness, aches, tenderness, and stiffness. Obviously, irregular menstrual cycles, sometimes with heavy flow or sometimes with scanty flow, also are seen nowadays. Bradycardia is one of the symptoms of hypothyroidism, depression, and memory issues. There may be some cognitive impairment or memory issues in the later stage, where there are severe cases of hypothyroidism where TSH levels are very high. There's a very famous concept of seven dwarfs of thyroid disease. Seven dwarfs of thyroid disease. These seven dwarfs are sleepy. So, as I said, lethargy and tired, they will be always nidra tandra, what is told in Ayurveda. They always want to sleep. They are not active. Pudgy, this is what is misunderstood as like pumpedness, right? You know, that is well nourished, hyper nourished, gol matol, khate pite karke, that is pudgy. Okay, that full puffy face, this is called as pudgy. Cranky are nothing but the issues with the temperament. A person who is suffering from hypothyroidism usually tends to lose the temperament. Very cranky type of personality. Muscle aches, weakness, all considered as achy. Puffiness, edemas, the legs, face, draggy, slow to active, slow in actions, lack of cheerfulness, lack of enthusiasm. They always are like draggy, you know, they are very much lethargic, slow. Okay, so these are called as draggy, and frazzly is one thing which also is related to the enthusiasm, cheerfulness issues. So these seven things are called as seven dwarfs of thyroid disease. Let's move on. Causative factors. The most common causative factor of hypothyroidism is autoimmune disease, which is called as Hashimoto's. We all know that. And you can confirm it by either thyroid scan. In early stage, again, it will not be there. Nodular goiter or Hashimoto's, etc., will be seen. Confirmation can be done by the neck USG, but most common is the Hashimoto's. If at all, because of goiter or some other nodules or glands, tumors of thyroid, if surgeons advise partial or complete thyroidectomy, then also the gland will not be able to produce the thyroid hormone which is required for the healthy living. And in that cases also, post thyroid surgery, we will have hypothyroidism. Radiations. Usually we see in the cancers of head and neck, any neoplastic lesions of the head and neck, if the doctor advises for radiation therapy along with chemo, so the radiation is not that intelligent to just burn the cancer glands present in the or cancer mass lesion present in the head and neck. It obviously the nearest organs are also affected. The nearest organs are also affected after the radiation therapy. So post radiation therapy, when we use to treat the cancers of head and neck, this will affect the thyroid gland, leading to hypothyroidism. Thyroid gland becomes weak because of radiation and hence can't produce the required amount of T3, T4 and hence leads to hypothyroidism. Then another common cause is thyroiditis. Inflamed thyroid gland may be due to an infection. Medicines, the only medicine which was noted by some research works is use of lithium in some of the psychiatric disorders where it leads to hypothyroidism. Very less causes of hypothyroidism are congenital issues because some children may be born with a defective thyroid gland or completely non-functional thyroid gland. It's very rare, if at all, because of congenital issues. If the gland is not healthy or it's completely non-functional, very rare case is congenital issues. Pituitary gland malfunctions. We all know this because there is a HPO axis and HPT axis, which is very much important for the functioning of the thyroid also and also ovarian health. So this pituitary gland, if it malfunctions, where adequate TSH it fails. That means in benign tumors of pituitary also we see hypothyroidism. Pregnancy. So very rare cases we see that the lady was healthy up till now, but once she gets pregnant, as we know that we have gestational diabetes, gestational hypertension, this also like gestational hypothyroidism. People develop lately during pregnancy hypothyroidism also. And last and the most common cause, which is the government is behind this, is iodine deficiency, which where the required amount of iodine is not present in the environmental things. And if you are living in a very tropical area where the environmental or the climatic iodine is deficient, and if the people are not consuming the iodized salt, there also you see hypothyroidism. Now coming to the complications of hypothyroidism. The only thing mentioned in Ayurveda is goiter. Except this, nothing has been mentioned, but we have to correlate with the present science, which the comparison with the dosha dhatu mala concept that we'll see later in the slides. The second most common complication of hypothyroidism is heart issues, peripheral neuropathy, infertility, birth defects, mixed edema, coma. Coming to the main topic, hypothyroidism and infertility. So we all know that hypothyroidism definitely affects the fertility rate of female by disrupting ovulation. So we see a people who are menstruating regularly, but it is a anovulatory menstrual cycle. The menstrual cycles may be regular, but ovulation doesn't occur. That is the major cause of infertility. But in some cases, there will be altered menstrual cycles, increased chance of miscarriage. So we have two cases right now. Our PG scholars of Kaya Chikitsa know that. We are treating two cases of miscarriage, increasing miscarriage. One lady, just now we did the thyroid profile test, it is normal. So we are finding other reasons for this cause, but still hypothyroidism may increase the risk of miscarriage. Also, it is often due to elevated TSH and prolactin levels. Now coming to the ovulation issue, How does ovulation affects in hypothyroid? Just brushing the knowledge for PG scholars or some students who are new to this topic. Disturbs the hypothalamic pituitary ovarian axis, which is famous as HPO axis. So when this HPO axis is disturbed, then it leads to an ovulation, irregular or sometimes heavy periods also. Let us further dive deeper into this concept of hypothyroidism and HPO axis, because this is the most common thing that is seen. The negative feedback sent by the estrogen towards the hypothalamus and pituitary will regulate the cycles regularly. The regular cycles will be there 28 or 30 days, but ovulation doesn't occur because we'll see that HPO axis. See, this HPO axis is disturbed by hypothyroidism by creating a high, that is TRH, which is nothing but thyrotropin releasing hormone, which further leads to high state of TSH. So once this TRH and TSH are high, this mechanism triggers increased prolactin levels, which further, once prolactin is increased, it suppresses the GnRH, that is gonadotropin releasing hormone. And gonadotropin releasing hormone, if you see from the hypothalamus, is released in a pulsating manner. It's not a regular flow, it's a pulsating manner. It ejects in a like a pulsating manner. So once this GnRH is suppressed because of increased prolactin, further reduces follicular stimulating hormone, which will not stimulate the Graafian follicle further. Luteinizing hormone, once the brush of luteinizing hormone, what you call the ejection, the peak of LH will support ovulation. But if doesn't happen, if this doesn't happen, the lady will not ovulate, and the negative feedback sent by the estrogen to the hypothalamus and pituitary will start the second cycle, but ovulation doesn't occur. So this further reduces FSH and LH, leading to dysfunctional ovulation, menstrual irregularities, and infertility. This picture you can find it on internet. I have taken from there only, and it is the normal HPO axis. If once you understand the normal HPO axis, then we can understand what happens in hypothyroidism. So HPO axis, just again brushing for students. This hypothalamus, as we discussed in the earlier slide, it increases or secretes the GnRH in a pulsating manner. Once this hypothalamus releases the GnRH in pulsating manner, pituitary will stimulate FSH. This I'm talking about the normal function of HPO. Whereas in the previous hypothyroidism, there was lack of FSH and LHS. So pituitary, when it secretes luteinizing and follicular stimulating hormone, further it stimulates the theca and granulosa cells of the ovaries. Once this stimulation of the theca and the granulation cells of ovaries takes place, estrogen is produced. Once estrogen is produced, actually it should go here. I don't know whether my pointer is visible or not. Just a second. Yeah. See this point, once estrogen is produced, this LH surge happens. Once LH is normal and the LH surge happens properly, then it further goes on to ovary release. Because of the LH surge, ovulation occurs and it is the ovulatory cycle, and the ovary shoots the ova into the fimbriae. But look here, if LH is not normal, if LH is less because of pituitary producing less FSH and LH because of high prolactin, what happens? From here, this point where I'm marking, there will be a negative feedback sent to the estrogen. See this negative feedback sent to the estrogen to the hypothalamus, and again the next cycle starts with ovulation. So this entire process is called as an ovulatory menstrual cycle. So hope this is clear. This is a very common thing what we see in people suffering from anovulatory menstrual cycle because of the deranged HPO axis. Let's move on. Okay. Miscarriage link, that is risk of miscarriages. This untreated hypothyroidism, let me remove these lines. Okay. Untreated hypothyroidism is associated with a high risk of early pregnancy loss. So here also early pregnancy loss means that first trimester is the most common duration, where the time period of the first trimester is the most common cause of early loss of pregnancy. And in severe cases, maybe the doctors are continuing by giving some support of progesterone, etc. But in severe cases, there may be stillbirth also in hypothyroidism seen. Pregnancy complications. If this hypothyroidism is left unmanaged, it can lead to preeclampsia also. Studies have shown that it can lead to preeclampsia because of high blood pressure, eclampsia and preeclampsia, high blood pressure during pregnancy, preterm birth, and also impaired fetal neurological development, because we know thyroid hormone, iodine, etc. are very much important for the cognitive development of the babies. If a lady delivers the baby normally also, if she is suffering from severe hypothyroidism during pregnancy, then the child may be born with the delayed milestones and cognitive impairment. It will not be a healthy child. This is because thyroid hormone plays a very important role in the brain development of fetus. So if the lady's thyroid hormone is less than the normal, the fetal development is going on, but the fetal brain development is not going on, which leads to the delayed milestones, cognitive impairment, and other issues related to memory or brain or neurological issues of the fetus. What I mentioned in the first slide about subclinical hypothyroidism, where T3, T4 normal, but TSH is high. We should not neglect it also, because it is the early stage where T3, T4 is maintained by the this axis of HPT, but TSH is trying hard to maintain the T3, T4. So that is called as subclinical thyroid. In this condition also, it contributes to fertility challenges, and is often recommended for treatment in women attempting to conceive. So if you find this subclinical hypothyroidism, that is the best time to treat a lady who is trying to conceive, eager to conceive. And that is very easy to manage also. Very rarely, even though the two pathogenesis are totally different, I have tried to correlate, because the latest research says that the pathophysiology going on in these two conditions, that is hypothyroidism and PCOS, are totally different but still are relative, because both contribute to the health of reproductive system in women. And if you Google very recently, this concept is developing high in the gynecologists of Western world, that they say that even though pathophysiology is different, but still they are relative, because we see both go hand in hand sometimes in patients of infertility. It is not compulsory that every patient of infertility will have both of these issues. That's why I'm saying that rarely, in some cases, we find hypothyroidism as well as PCOS running hand in hand. So in this condition, let us throw some light on this condition also. That is, see how we are relating this. The latest research says that there is a rise in thyrotropin releasing hormone, that is the TRH, which we saw previously in the HPO axis. Increased prolactin and thyroid stimulating hormone will be the further stage once there is a rise in the TRH. TRH rise leads to increased prolactin and TSH. So this prolactin will cause polycystic ovarian morphology. Polycystic ovarian morphology, because it inhibits ovulation. Once ovulation occurs, the Graafian follicle will be shrinking into corpus luteum. But ovulation doesn't occur, there is no chance of corpus luteum because LH is less. So what happens? That Graafian follicle remains as a cyst. And next month, every month it will be same thing happening. Ovulation is not occurring. That's why we see the polycysts, different cysts in the surrounding of the cortex of the ovary. And this inhibiting the ovulation, change in the ratio of FSH and LH, and increased DHEA, that is dehydroepiandrosterone. DHEA, there is a very high trend a few years back about issues with memory, learning, etc. Complan with DHEA, Horlicks with DHEA, Bornvita with DHEA. So DHEA has a role in fertility also. So this is usually secreted from the adrenal gland. Increased TSH also contributes due to its spillover effect on FSH receptors, and this increased collagen deposition in ovaries as a result of hypothyroidism. So it's a very new concept, that deposition of collagen. We might have seen deposition of collagen in the kidneys, deposition of the plaques in the brain in Alzheimer's. So similarly, there are some collagen deposition on the ovaries which will affect the healthy tissue of the ovary, resulting into hypothyroidism also been suggested. So this is the pathophysiology of PCOS in primary hypothyroidism. The primary hypothyroidism, just now what we studied, this is presented in the schematic diagram form. Same thing, increased prolactin, increased TSH, decreased frequency of GnRH, increased FSH, relative LH, follicular system, cyst, increases adrenal DHEA, follicular maturation arrest, and once the follicular maturation arrests, then there will be no ovulation. Spillover effect of FSH receptors and deposition of collagen on the ovaries, destroying the normal tissue of the ovary, leading to unhealthy ovaries. Now coming to the second point, hypothyroidism in pregnancy. Once pregnancy sets up, if hypothyroidism is there, the only choice remains to supplement thyroid hormone. Nothing much can be done in that stage. The common type of hypothyroidism in pregnancy is autoimmune thyroiditis, which is again known as Hashimoto's. Two main hormones may influence thyroid function during pregnancy, that is human chorionic gonadotropin and estrogen. In pregnancy, the only two main hormones that affects the thyroid function is HCG and estrogen. High levels of HCG during the first trimester may decrease TSH, which returns to normal in later pregnancy. That means nothing is needed. Nothing intervention is needed in these cases. It is physiological sometimes that high HCG will affect the thyroid, which leads to decreased TSH, which will return to normal in the further stage. That means it is most common, no need of any intervention. But if it not comes to normal, then we have to intervene, or else the child will be suffering. Now, estrogen, what it does? Estrogen increases the total thyroid hormone levels, but the free hormone usually remains normal. FT3, FT4, they remain usually normal, but hormone levels are increased. So this risk of hypothyroidism in pregnancy may be classified as maternal risk and fetal risk. There are two issues, maternal risk and fetal risk. If a pregnant lady is suffering from hypothyroidism, she will be having risk factors like anemia, myopathy as discussed in the first slides, preeclampsia, congestive heart failures, placental abnormalities, and postpartum hemorrhage. These are listed as the maternal risk of hypothyroidism during pregnancy. Now let's see what are the fetal risk. Fetal risk are very few, but also to be noted very seriously. Impaired brain development, just now I told, that is thyroid hormone really is very much essential for the brain development. Severe cognitive impairment, neurological abnormalities, developmental issues, and delayed milestones will be seen. Coming to Ayurveda perspective. Hypothyroidism Ayurveda, It is my understanding and what my gurus have told in Jamnagar that it falls somewhere under the heading of Kaphaji Anatmaji Vikara, but cannot name certain condition of Kaphaji Anatmaji Vikara. Charaka says Vikarana ma kushalo na jimiyat kadachanaha nahi sarva vikaranam namato asti drastitihi. Don't be ashamed that if you can't name the disease, because the entire nomenclature of the disease is not possible. Nahi sarva vikaranam namato asti drastitihi. Then what to do at that condition? Again, Acharya Charaka gives the example of whenever you fail or you feel difficult to name a disease, just concentration on the Taratama Bhava of the doshas, the permutation and combination of doshas, and then treat it. So that is why our understanding of hypothyroidism in Ayurveda is falling somewhere under the broader umbrella of Kaphaja and Anatmaja Vikara. Because when we see Kaphaja and Anatmaja Vikara and the symptoms of hypothyroidism, I will show you, it links very beautifully. Vis-a-vis, in relation, ditto ditto it relates. One of the resultant condition of hypothyroidism, which is goiter, is mentioned in Ayurveda in all the classical texts like Galaganda, Gandamala, etc. So that is common. See here also, if you see, again the first word dosha, culprit here is Shleshma. Yasya Shleshma prakopito galabahyo avatishtate. Galabahyo, external of the neck, which is nothing but the thyroid gland. And who is the main culprit? Kapha. That is why I have tried to impose that hypothyroidism fits somewhere under the broader umbrella of Kapha Anatmaja Vikara. Shanaihi Sanjanet Shofam. The inflammation of the thyroid gland or the enlargement of the thyroid gland is very gradual. In this Kaphaja Vikara, Galabahya Avatishtate, Galagando Asya Jayate leads to goiter or Galaganda. This is the only thing mentioned about thyroid gland in Ayurveda. Even Gandamala is not thyroid, it is cervical lymphadenopathy, submandibular lymphadenopathy, that may be tubercular or some other conditions. But still, the only thing about thyroid gland is Galaganda, which also comes under the Kaphaja Anatmaja Vikara. Let us see. See here, I have marked it. This is from Charaka Sutra 20, Maharogadhyaya, where Nanatmaja Vikaras are told. Now let us think these 20 diseases, keeping in mind the perspective of hypothyroidism. हम सब लोग अभी हाइपरथायराइडिज्म के सिम्टम्स को ध्यान में रखते हुए इन सिम्टम्स को देखेंगे, इन डिसीज को देखेंगे, दैट इज द 20 डिसीजेस ऑफ कफजनत्मज विकार. श्लेष्म विकारांश विंशतिम अतः ऊर्ध्वं व्याख्यास्यामः तद्यथा तृप्ति. Actually तृप्ति also comes because there will be some hunger issues also. Tandra, see that P.G.D.Y.N, what I mentioned in the seven dwarfs, sleepy, pudgy, draggy, tandra, pre-stage of nidra, drowsiness, exactly matching with hypothyroidism. Nidradikyam, sleepy. Sthaimityam, that is because of sthaimityamiti ardravastra achhadanam, Chakrapani commentary, not here but somewhere else. You feel dampness, increased moisture. You feel as if a wet cloth is um, put on your body, wherever it is, like it may be on the neck or wherever you feel that stymithia. It is the feeling of dampness, more clay in the body. So this is also seen in hypothyroidism because you have pitting edemas, you have swellings, you have put on weight, you are lethargy, you are dull, etc. Guru Gatrata, same heaviness, increased weight, heaviness. Guru Gatrata, hyperthyroidism increases weight. Hypothyroidism decreases weight. More often, the patient feels hunger in hyperthyroidism, which is nothing but Atyagni of Charak Samhita, mentioned in Grahini last part, that is Bhasmaka Roga. So these two conditions, it is the duty of we teachers to guide the students properly, that even though hyper and hypo directly not mentioned, but there are certain conditions where you may relate them and treat them accordingly as per the doshic predominance, you may get the success in clinical practice. Alasya, next symptom what I marked in yellow is alasya, which is nothing but again lethargy, draggy. Okay, apakti, hridayopalepa, galaganda, atistaulyam, overweight. See, these are 20 diseases of kapha, but still Hypothyroidism is not a single disease, it's also syndrome because it affects many organs. Actually, PCOD, now it's converted to PCOS, it's syndrome. And here also, kapha jananaatmaja vikaras are a group of different diseases, 20. Among them, at least 10 here you are seeing that they are included under the hypothyroidism heading. And Galaganda is directly mentioned. Kapha jananaatmaja vikara. Atisthaulia, putting on weight. So I hope my point is understood and taken positively in a good spirit of Ayurveda, that we are trying to correlate something which is not mentioned in Ayurveda, but looking at the doshic predominance, we will be treating it further as this condition only. So, if this is the case of Kapha Jananatmaja Vikara, what about infertility in Ayurveda? There are many things mentioned. Complete Yonivapat Chikitsa is there in Sharirasthana. There is the concept of Narashanda, Narishanda, etc. All acharyas, right from Charaka, Shushruta Vagbhata to Bhava Prakasha, Yoga Ratnakara, everybody have mentioned about infertility, but different conditions. But looking into the research done, there are many conditions where you can compare, like Pushpagni Jataharini. Your president, respected Dr. Kamini ma'am, we both were experts in Hyderabad for the workshop of PCOD conducted by RAV. So there were only two people other than for the gynecology, that is me of Kaya Chikitsa and one more senior person from Kaya Chikitsa. So looking into our practice of gynecology, we have been invited as the resource persons there. And madam, I met her when I was PhD scholar. She was in Jamnagar, and she only, I'm thankful to her that she suggested my name for this webinar. And in that condition also, we discussed about this condition where Bob Kashyapa mentions the condition called as Pushpagni Jataharini. Arajaska mentioned in Charaka. If you see the symptoms, somewhat closely relates to infertility. Artava Kshaya Nashtartava. It may be like oligomenorrhea, amenorrhea. Nashtartava may be menopause, may be physiological, sometimes pathological early. But all these issues will relate to fertility in women. Okay, so these are mentioned by Acharya Charaka, Artava and Nashtartava, Kshaya. Now, Jataharini mentioned by Kashyapa. Why I'm throwing more light on this? Because the symptoms mentioned are very much close to PCOD and hypothyroidism also. We are amazed to know how did Kashyapa mention two important things, two important words in this Jataharini, Pushpagni Jataharini. Let us discover this. It is a group of diseases, rather a single disease. If you see Kashyap Samhita and see this, I think it's mentioned in Sharirasthana or somewhere, I'm not remembering now. But in Kashyap Samhita, this Pushpagni Jataharini is mentioned as a group of diseases. It has a wide range of etiological factors. Signs and symptoms are also related to physical, psychological, social, and spiritual issues. Just as we are discussing about hypothyroidism and PCOS, it's not a single relative thing. It is physical, psychological, social, and spiritual issues. Obviously, hypothyroidism and PCOS, there is no chance of spiritual issues in allopathy because modern science doesn't believe in this. But Ayurveda, in Kashyap Samhita, they have added one more aspect of this Pushpagni Jataharini is spiritual issues. And we do follow this in OPD. Everything is normal, but still the lady is not conceiving. Then definitely it is Daiva. It may be her bad luck, or it may be something which is beyond the understanding of medical science. And if I say this in a contemporary conference, they will laugh at us. But still, some people may agree, those who understand that science is not everything. There are certain limitations for the science. The syndrome of Jataharini doesn't just affect the women, it also affects the fetus. See, just now we discussed. Hypothyroidism will not just affect a pregnant lady, it also affects the fetus. Same thing is told in Kashyap Samhita that this Jataharini Pushpagni is also affecting the fetus also, neonates also, and children also. One condition named Pushpagni Jataharini, there are many Jataharinis. Just for information. If you're interested, please refer Kashyap Samhita. You'll enjoy the concept of Jataharini. And one among the Jataharinis is Pushpagni Jataharini. This inflicts women in their reproductive period only. So here comes the interesting point of infertility. Reproductive period only. This type of Jataharini, that is Pushpagni Jataharini, a type of Jataharini affects the reproductive period. In Pushpagni Jataharini, there are some physical signs like Sthula and Lomashaganda. See how beautiful it is. Sthulaganda, puffy face, not like Cushing syndrome, full moon face, but still in hypothyroidism, we see, even in PCOD, we see a lady has a pompent, full, rounded face. Sthula ganda, ganda is cheeks. Cheeks are swollen, plumpy, rounded. Lomasha ganda, very scientific. More facial hair. May not be directly called as hirsutism, but still in PCOD and hypothyroidism, one of the signs you see is the hair coarse and dense, and facial hair will also be more. So hats off to Kashyapa, he mentions Loma Shaganda, face pe jada hair. If it is men, it's fine. In women also, the facial hair will be increased. We see this in both PCOD, hypothyroidism, and glucose intolerance. This indicates hormonal as well as metabolic irregularities. So the concept mentioned by Kasyapa, if you think deeply with the presence of mind, Shastra Baddha Uhapoha, that is Vitarka, it is taking us towards hormonal as well as metabolic disorders. And one word again mentioned in in Kashyapa Samhita, the other clinical feature related to menstruation in lady suffering from Pushpagni Jataharini are Vrita Pushpam, Pushpike Bina, यथाकालम प्रपश्यति, टाइमली पीरियड्स आएगा. दैट मीन्स मेंस्ट्रुअल साइकिल आर रेगुलर. यथाकालम प्रपश्यति, प्रपश्यति दिखाई देगा, पीरियड्स दिखाई देगा, मंथली करेक्ट टाइम पे दिखाई देगा. वृथा पुष्पम, वृथा विदाउट, पुष्पम ओम. व्हाई डोंट वी कंसिडर पुष्पा एज ओम? The trend in Ayurvedic students nowadays is you have to say om only. If I say pushpa, it's unscientific. Okay, so not like that. In olden days, what was the dominant language? They are mentioned in that language. If I don't consider Mata, I consider mother. It's unscientific, right? That means, why don't we consider this Pushpa as Om? Vrta Pushpam, without ovulation, Yatha Kalam Prapashati, timely menstruation ho jayega. Which means, the lady gets menstrual cycle regularly, but it is unable to conceive because anovulatory menstrual cycle. So this is a very mind-blowing concept mentioned by Kashyapa in his Samhita. Now, Charaka's view, Arajaska Yoniapath, caused due to vitiated pitta making sthana samshaya in the yoni and garbhashaya leading to karsya and vaivarnya. So here karsya is not hypothyroidism. Vaivarnya may be pallor and panduta, but it is one more cause of infertility is Arajaska. Chakrapani, using his logical understanding of Arajaska, has mentioned Arajaska is the anartavaha. So except if you consider karsya, in hypothyroidism karsya is not there, it is actually staulya. But anarthava is there. That means the delayed periods, or sometimes 2 months, 3 months, 4 months, there will be no periods. In the fertile age, I'm not talking about menopause. I'm talking about young ladies of 24, 25, 26. They will be having no periods for 5 months, 3 months, 4 months. We see it clinically. So, anarthava, arjaska, maybe because the only conflict of interest here is karsha and staulya. But just I'm throwing light. So as she is emaciated, there is discoloration of the body, which means she is weak and anemic, and also no bleeding at all during periods. So it indicates the pathological amenorrhea, not menopause. That's what I said. Probable samprapti. Looking at all these conditions, we want to conclude about the doshic predominance. It seems that the features are closely relevant to one or the other symptoms of infertility, where you see the first thing what we have to do as Ayurvedic doctors, we should not try to compare hypothyroidism and infertility with any condition of Ayurveda. That is the wrong thing. No need to compare. We just have to try to analyze the doshic involvement in such conditions and then we can treat. So by deeper analysis, what I feel personally, this is a Kapha Pradhana and Vata disorder. That's why hypothyroidism, PCOD, Kapha Jananatmaj Vikara symptoms are matching. Why I said Vata, I'll tell later. The inspiration of adding Vata here is Sushruta. Kapha dominant, Vata associated. That means it's a Kapha Vataja Vikara. Now look into this. This shloka will blow your mind. And this is not mentioned in any infertility. Thanks to Guru Nam Guru, Vaidya Guru C.P. Shukla sir of Jamnagar, who was not the teacher in Jamnagar at that time when I was doing Ph.D. during 2007 and 9, but we are so lucky that we used to go to his house to study Charak Samhita. This shloka once while teaching about Vataji Gulma, and if you are having Charak Samhita right now with you in your home, you can refer Charaka Chikitsa 5, Gulma Chikitsa. In Pittaji Gulma commentary, Chakrapani mentions this shloka. See the ethics and beauty of Ayurveda. Chakrapani, being a later Acharya, doesn't do plagiarism. He gives a due respect towards the Shushruta's concept of this shloka and mentions in Vatagulma commentary Shushruta shloka of this one. No plagiarism. Referential system was there during Acharya's time also, and we should be proud that this was in Ayurveda. This shloka of Shushruta Samhita regarding Vatagulma will blow your mind, and I have given the reference of this picture of a water bubble. Because the shloka says like that. Sayasmad atmani chayam gacchati apsuiva बुबुदाहा. पानी के ऊपर जैसे बबल होता है वैसे नेचुरली आतगुल्मा अपने आप बढ़ेगा. सयस्मात्, दैट थिंग विच आत्मनि चयम गच्छति, अपने आप बढ़ेगा. आत्मनि चयम गच्छति, कैसे बढ़ेगा? अपस्व बुद्बुदाहा, एज अ बबल ऑन द वाटर. It will naturally get enlarged as the air fills into the water. A bubble is enlarged and it will stay for some seconds and it will अपने आप फूट भी जाएगा, मतलब it will break open automatically, it will burst open automatically. See the second line, अंतःसरति अस्माच्च, अपने आप अंदर जाएगा. अंतःसरति अस्माच्च न पाकम उपयात्यतः, there is no chance of inflammation. That is why Charaka was wise enough to say that there are three conditions of gulma only in Pittaji gulma: ama, pachamana, pakwa. But Vata gulma never gets pakwa because there is no inflammation, there is no rakta, there is no pitta, there is only Vata. Now imagine water as kapha, because in Ayurveda it is told that body में kapha water के form पे है, mean water kapha के form पे है. तो जब आप एक ग्लास में वाटर लेंगे और एक पाइप लेके उसमें एयर ब्लो करेंगे, what will happen? There will be air bubbles. There will be air bubbles. And those air bubbles will stay for certain time and अपने आप फूट भी जाएगा, मतलब it will be burst open by itself. Now just imagine here, I'm trying to compare this relation of, see, please excuse me that I'm not relating Vata Gulma with ovulation. I am taking the concept of Vata Gulma mentioned of Charak Samhita and I am trying to apply in somewhere else. Because this is happening inside our body, it may happen anywhere. It's not just that it should occur somewhere in the ovary or somewhere in the uterus like Rakta Gulma, where you have pseudo pregnancy, phantom pregnancy symptoms like Rakta Gulma. But everything is somewhere relating. Ayurveda is so beautiful that everything is somewhere relating. Now, when I say Atmani Chayam Gachati, I start from here. Okay. I start from here. That is, I start from primordial follicle. यहां से जब प्राइमरी फॉलिकल बढ़ता जाएगा, सेकेंडरी फॉलिकल, then comes to early antral follicle, up to antral follicle, all these hormones you are seeing here. But see, from this size to this size, व्हाट सुश्रुत सेज, आत्मनि चयम गच्छति, अपने आप बढ़ते जा रहा है। आत्मनि चयम गच्छति, अप टू द एंटल फॉलिकल स्टेज, अपने आप बढ़ते जा रहा है। कैसे बढ़ेगा? अपस्वय बुदबुदाहा, एज अ बबल ऑन द वाटर। Once it shoots the ovum, once this follicle shoots the ovum, अंतस्सरति अस्माच्च न पाकम उपयात्यतः। अंतस्सरति, अपने आप अंदर जाएगा, अपने आप रिग्रेस हो जाएगा, अपने आप कार्पस लुटेम हो जाएगा। न पाकम उपयात्यतः, यहाँ पे इन्फ्लेमेशन और सपुरेशन, पस फॉर्मेशन का चांस ही नहीं है, बिकॉज ये फिजियोलॉजिकल है। कहाँ का वातगुल्म और कहाँ का ओवुलेशन वी आर रिलेटिंग, सही लगे तो ही इसको एक्सेप्ट करना, नहीं तो यू कैन ऑलवेज, यू आर वेलकम टू कमेंट ऑन मी, डिनाई द कॉन्सेप्ट्स। नाउ थिंक केयरफुली, if water and air is there, healthy water is there and air is also healthy, this is happening every month, it is happening every month, it is happening. You are welcome to answer my question. What if I add a little bit of soap powder, detergent powder to the water? If I add a little bit of detergent powder to the water and blow the air, what will happen? Unfortunately, we are not in a live class so that you can answer me, but you can answer yourself or you can comment on the messages. अगर हमने उस पानी में थोड़ा सा सोप पाउडर, डिटर्जेंट पाउडर ऐड कर दिया और हमने एक पाइप लेके पानी को ब्लो कर दिया, तो क्वेश्चन इज वेदर द bubbles will increase or decrease. Answer should be increase. Second one, whether the bubble stays for a long time or whether the bubble vanishes in a new, more bubble will form. Correct. Dr. Rima has answered. Air bubble increases. सेकेंड क्वेश्चन इज, वो बबल लॉन्ग टाइम रहेगा या फिर जल्दी खत्म हो जाएगा? इसका भी आंसर है, इट विल नॉट वैनिश क्विकली, इट विल स्टे फॉर लॉन्ग टाइम। समबडी हैज कमेंटेड वैनिशेस क्विकली, इट इज रॉन्ग। सोप पाउडर ऐड करेंगे तो हाउ कैन इट विल वैनिश क्विकली? इट विल नॉट वैनिश क्विकली, इट विल स्टे फॉर अ लॉन्ग टाइम। नाउ कमिंग बैक हियर, if soap powder is added, that means I am adding soap, means it is nothing but kapha. पानी के साथ विशेषड कफ रहेगा और वायु जो है वात रहेगा। वात जब भी पानी में से पास होगा तो बबल आएगा, और कफ विशेषड है, मोर क्लेद है, मोर पिच्छल है, मोर पिच्छल है, स्टिकी है। तो जब वात उसमें से पास होगा तो बबल बड़ा बनेगा और लेट भी रहेगा, दैट इज नथिंग बट पीसीओडी। ज्यादा बबल्स भी आएंगे। अंतःसरस्य अस्माच्य नहीं होगा बिकॉज इट इज नॉट नॉर्मल वाटर। इफ इट इज नॉर्मल वाटर देन अंतःसरस्य अस्माच्य मीन्स इट विल बी ग्रेजुअली, अपने आप जाएगा। लेकिन यहाँ पे कफ है इसलिए अपने आप नहीं जा रहा है, वो लेट रह रहा है और नेक्स्ट मंथ का और एक रह रहा है, नेक्स्ट मंथ का और एक रह रहा है, दैट मीन्स इट्स बिकमिंग पीसीओडी। Okay, that's why I said you all have the rights to criticize my point, but I am trying to correlate something with Vata Gulma to Vata Kafaja Gulma, which is not there, but it is there. Okay, Vata Kafaja Gulma type नहीं बताया तो नहीं, ऐसा नहीं है. Okay, when there is a normal following of the disease concepts, the Dvidosha and Tridosha will not be explained. Nishaya Gulma is explained. Dvidosha will not be explained, but it's to be understood. So coming to this point, when kapha increases, more bubbles, more long time, nothing but PCOD and PCOS. And Parshva is one of the type of place where it is seen in Vatagulma. दो पार्श्व है वातगुल्म में. Organizers, there is some distraction, I think. Can you mute everyone? एनीवेज, आश्रय आश्रय भावा, जस्ट नाउ आई टोल्ड, पिछलता अगर कफ का इंक्रीज हो जाएगा देन बहुद्रव श्लेष्मा एंड बहुअबद्ध मेधस आर द टू कॉन्सेप्ट्स इन प्रमेहा. एंड इफ यू सी इन पीसीओडी, इफ यू सी इन एनोलेटर साइकिल, मॉडर्न वाले क्या देंगे? मॉडर्न वाले क्या देंगे? एंटी डायबिटिक्स ही देंगे. दे विल गिव मेटमॉर्फिन, दे विल गिव ग्लिमिक प्रोपाइड, दे विल गिव other things which are anti-diabetic only. Now, PCOD, hypothyroidism, Bahudravashleshma, Bahuabadhamedas, Prameha, Charaka, Nidhanasthana. It's not mentioned in Charaka Chikitsa, it is mentioned in Nidhanasthana, Bahudravashleshma, Bahuabadhameda. And यही तो मॉडर्न वाले दे रहे हैं एंटी इन एनुलेटरी साइकिल्स पीसीओडी ग्लूकोज इंटॉलरेंस ओके सो somewhere in our mind we have to relate these concepts with modern concepts. That is why in PCOD we do find obesity and diabetic like features like insulin resistance and sometimes dyslipidemia also. This leads to irregular menses and anovulatory menstrual cycle. Treatment: lifelong HRT. Allopathy says lifelong HRT, hormone replacement therapy. Only the treatment of choice in hypothyroidism. Main treatment: leothyroxine, that is T4, in a standard dosage, most effective and safe daily medication for replacing the hormones which your thyroid cannot produce. Alternative options are, in some cases, leothyronine, that is T3, or natural thyroid extract, Armour thyroid. Nowadays, you can Google on this, may be used, though leothyroxine is generally preferred due to its consistent potency. T3 is not preferred, T4 is preferred. And dosage, please fix it with an endocrinologist. Okay, so sometimes if we, being not qualified, at least in Maharashtra, it's allowed to practice allopathy, but in Karnataka, it is not allowed. But still, people are practicing. But I'm not telling about giving hormones. Giving hormones, if not calculated properly, may end up into hyperthyroidism, which you don't want. That is why, please refer the patient to endocrinologist. Let them do all sorts of tests and decide whether it is 75 mcg, whether it is 50 mcg, whether it is 100 mcg, whether it is 88.25 mcg. So they will calculate. They have that ratio for calculation. That is the only treatment in allopathic science. ज़्यादा कुछ नहीं है उसमें. Coming to Ayurveda. See, Kapha Jananaatma Vikara. First thing is Vamana. And if associated Pitta is there, go for Virechana. Okay. Next, apart from these two therapies, Lekana Basti. We have given Lekana Basti and Kshara Basti in cases of PCOD. Believe me, there are results. Because Kapha, Kleda, Pichilata increase हुआ है ऐसा मैंने कहा अभी. Whenever there is a Kleda and Pichilata increase in the Kapha, please use Lekhana Varga, Lekhaniya Dashemani, Truptigna Dashemani, Deepaniya Dashemani. Charaka Sutra 4. See, Trupti, first symptom of Kaphacharanatmaj Vikara. बिना खाना खाए ही पेशेंट को पेट भरा जैसा लगना. One of the Kaphacharanatmaj Vikara. So, Truptigna Dashemani, if you see in the Sutra Sthana 4. Lekhana Ksharabasti may also help in the management of hypothyroidism and PCOS if the patient is obese, especially go for this. If there is dyslipidemia, obesity, please go for this. Kshara and Lekhana Basti. Hence, all that is Prameha Nashaka Chikitsa, I repeat, whatever is the Chikitsa for Prameha in Ayurveda, where we concentrate on Kaf Abadhamedas and Bahudravashleshma, Vata Kafara Chikitsa, Abadhamedohara Chikitsa, all are the beneficial treatments for PCOD and hypothyroidism. No doubt. Try it. This is the concept. Bahudravashleshma, Bahubadham Medam. इसके बारे में बहुत सारे बोल दिया गया है. अबद्धम मेदम मांसम शरीरम क्लेदम. ओके. नाउ सी स्थौल्य चिकित्सा. इसके बारे में और एक घंटा बोल सकते हैं लेकिन टाइम हो गया है. सब लोगों को ये सिखाते हैं कि गुरु चापतर्पणम प नहीं है इसमें. माय स्टूडेंट्स नो दिस. बट स्टिल मेनी टीचर्स टीचर्स गुरु चापतर्पणम प नहीं है. गुरु च अतर्पणम. वाई गुरु फॉर अग्नि, अतर्पणम फॉर मेदा. That is why modern doctors prescribe antidiabetics in PCOD. Kafara, Kledhara treatment for hypothyroidism, Shilajatu, Gugulu, Gomutra, Agnimanta, Dashimula, Varuna, Tilaguda, Trikatu, Panchakola, etc. may be beneficial in managing PCOD. Because all these are Kledhara, Pichilahara, Kafahara, Rasayana, especially Shilajatu, Gugulu, Varuna, Dashmula, Agnimanta. All this we try in our clinical practice. Whatever is stored for Galaganda Chikitsa, like Kanchana Gugulu, Shilajatwadi Vati, Shivagutika, Varunadi Kashaya, Shatapushpa Tailanasya. Dhiman madam only discussed about this. In controversy about Shatapushpa, you can ask my students now, PG scholars, whether it is sonf or the dill. Dill in Kannada we call sabraski. Okay. So dill ka bija, parpata bija is Shatapushpa. And some controversy is there. This bade sonf what we eat, no? Anatham sova. That's also sometimes people call Shatapushpa, but one of the senior most Dravyaguna expert told me that the dill bija only, the seed of dill only should be called as Shatapushpa. So Shatapushpa Thailandasya, we discussed a lot in 2 days conference in Hyderabad with Dhiman madam. And it is said to be beneficial. We are trying it, but not yet known the results. We are in the phase of trial this one. This last formulation, I used my Yukti. You cannot find this in the market, but we make it in our pharmacy of the college. Concept is very simple. Dashamula is Shotagna. If you see Dashamula, Shotagna Dashamani in Sutrasthana 4, Apamargakshara for Lekana effect, Kafahar effect, Medor effect, and Sarshapataila base. आप भी बना लो फॉर्मूला इज वेरी सिंपल इन फ्रंट ऑफ यू सर्षपतैल बेस में दशमूल कषाय कल्क ऑफ सर्षप अपमार्ग क्षार इन तीनों को बना के सर्षप तैल बना लो एंड गिव इट फॉर एप्लीकेशन ऑन गोइटर गलगंड see the results and get back to me. Why did I use sarshapa tela? Because this concept has been inspired from charaka sarshapa kalka lepa in shlipada. In elephantiasis, charaka mentions in Trishothiya and the Shweta Chikitsa Adhyaya, sarshapa kalka lepa is mentioned in shlipada, elephantiasis, filariasis. And even on Galagand also you can apply this. So I thought it will be very tedious for the people to apply Sarshapa Kalka because it will not, they have to lie down supine on the goiter swelling. So I am talking this for nodular Hashimoto's and goiter only. Base should be Sarshapa Taila, which is Katu Taila, Tishna Taila, synonyms. Apamarga Kshara for Lekan effect. Dashmula Shotagna. We have documented a case of small nodular goiter where after 2-3 months of application of this, the entire swelling is gone. We have photographs of this. Conclusions. I'm sorry if they have taken more time, but this is the way I teach. Hypothyroidism is infertility and often found associated both together. The only choice in allopathic science is supplementation of thyroid, where T3, T4 levels, in worst cases, where T3, T4 levels are reduced. Healthy diet, lifestyle modification, and optimum physical activity keep the obesity and glucose tolerance under control, which are also very useful. We have to have a healthy diet, no junk foods, keep physically active, lifestyle modification, no divasapna, no eating of junk foods. Okay, optimum physical activity. Shodhana Chikitsa of Ayurveda, as I said, Vamana, Virechana, Lekana Basti, Virechana, wonderful results. Virechana, Bijam Bhavati Karmakam. See, Bijam Bhavati Karmakam is told in Virechana. Bijam, Om, Bijam, sperm, both will become active. So, this Shodhana Chikitsa, especially Panchakarma Chikitsa, Vamana, Virechana, and Lekana Basti are beneficial in the management of hypothyroidism and infertility. Thank you very much. I apologize for taking 13 minutes extra, but I think it will be considered. Back to organizers.
Wonderful
Thank you, sir.
presentation, sir. You are truly, it was up to the, you nailed it, and it's a very detailed with simplified manner you have told us. And just one query, we considered PCOS and the hypothyroidism with in obesity. But sir, can you enlighten on the lean PCOS hypothyroid and its pathophysiological correlations?
Sorry, madam, can you come once again? I didn't get your
Yes,
point.
lean PCOS, lean PCOS.
Okay.
Right. Its pathophysiological correlation regarding to Ayurveda and like modern also.
You mean patient if it is lean, but she is having PCOD.
Yeah, lean PCOD means
Yeah,
the lean
their
PCOD.
only understanding, yes, this question was asked by one of my student who was just working as assistant professor in one of the college in Kaya Chikitsa. So I tried to give her the satisfactory answer in the form of again doshic predominance. In obese PCOD, we have to consider kapha dominant vata associated, whereas in lean PCOD, we have to consider vata dominant kapha associated. The treatment remains virechana first in lean PCOD,
Yes.
and in obese PCOD, first we have to go for Vamana, virechana, followed by Ksharavasti.
Okay. So
Because you're
the
right, madam. Because I hope you are also senior gynecologist. Because when I was a student, we always seen PCOD as very heavy, overweight, pumping. But now you are truly correct. We see in our clinical practice, BMI less than 18 also, BMI less than 19 also, they
yeah.
have PCOD.
Yes, sir. Because even I have operated lean PCOS patient with having a huge ovarian cyst in puberty age also. So these people they are getting the problem since from their puberty age.
Exactly,
So
madam.
yeah. So dealing with such patients and gaining their weight also, considering their even the Ayurvedic treatments, we need to follow some protocols like that. There should not be any dominance of the dosha while treating with the means we are treating PCOD, considering kapha vritta like what. But uh, when we actually treat that patient, I used to give them a Mrudu Virechan, not exactly the Virechan.
Yes,
So,
ma'am.
yeah. And even in the patients like having the hypothyroidism, known case of hypothyroidism, when they come as to during the OPD period in the first trimester and knowing her as a hypothyroidism, then when we do the TSH level also, at that time if the we want to give them a ayurvedic treatment, if the TSH means if she is having a subclinical hypothyroidism having the free T4 normal range and increase TSH level up to 5 or more than a 5, at that point means what we should think about the ayurvedic management in such cases. If she is already on the levothyroxine taking 75, shall we reduce while means levothyroxine dose while giving them an ayurvedic medicine, or shall we can give these medicines along with that levothyroxine? How we will deal in such patients, what we should taste investigate before that?
First thing, madam, it would be ethically wrong to stop levothyroxine at once, because
Yeah.
once it is an established treatment, and we are not in that acharya's period that people will not question us, because
Yeah.
we are also in a learned society where people may question us, and they may consider it as unethical practice to stop levothyroxine at once. So what we shall do
Mhm.
is, let us leave that concept with the endocrinologist, and also we can continue to give it. And along with
Mhm.
that, if we start Ayurveda like Shiva Gutika, or even as you
Mhm.
said, Mrudu Virechana is an excellent choice, because already patient is lean
Yes.
and thin. So you are not supposed to give
Yeah.
Tikshna Virechana. Okay.
Yes.
So Mrudu Virechana or Nitya Virechana, just Erandabhrishta Haritaki. What I have seen is
Okay.
Erandabhrishta Haritaki also every day, if you keep it 1 teaspoon with warm water. So
Mhm.
there the dosha sanchaya will not take place. And Haritaki Shoshana, it is Kledahara. And Erana is
Mhm.
Anulomana, Vatakafara. So this Erandabush Haritaki or any other Murdu Virechakas, every day if you keep, and
Mhm.
giving Murdu Virechana, Nitya Virechana followed by Shivagotika, or even Varunadi Kashaya or Shilajatwadi Vati, see it
Mhm.
gradually for 2 3 months. And once, because we cannot expect hormonal changes in 1 or 2 months, you know that it's practically it's
Yeah.
very difficult. So once the
Mhm.
lady is clinically okay, and
Mhm.
once you find that her TSH levels are coming down gradually, then we can take a call discussing with the endocrinologist to reduce the dosage. And
Mhm.
in such cases, after some few months, if you go for ovulation studies,
Mhm.
follicular studies, there may be some positive ray of hope, what I consider.
Okay. Okay, sir.
Try Gomutra, madam. Gomutra is excellent.
Okay.
If
Okay,
people
sir.
are
Okay.
not willing to take Gomutra, give them Gomutra Arka or Gomutra Bhavita Shilajatu,
Okay, sir.
because
Okay.
it's a miracle. I know that. Lekhana property.
Thank you, sir. Thank you so
You're
much.
welcome.
Pradipta, continue, beta. Dr. Neha, please
Yes,
continue
ma'am.
in the
Yes.
questions. Yeah. Yeah.
Yes. I request delegates to put their question in chat box. We already have some questions. Sir, we have a question in chat box. Shalya Pushpa Tailanasya, which one is best, Marsh or Pratimarshanasya?
If patient can come to Panchakarma every day, please go for Pratimarsha only. And if they are not, like if they are busy working, then even Pratimarsha Narsel is okay. Even Pratimarsha Narsel is fine. We have given patients, हम वो ड्रॉप्स पेशेंट को दे देते हैं, सुबह सुबह दोनों नॉस्ट्रल में दो दो ड्रॉप्स डाल दो प्रतिमर्श नस्य, दोनों कर सकते हैं.
Okay,
Which one is
thank
the
you, sir.
best? Then Marsha is best. Obviously, Marsha is best.
Okay. Sir, one more question. Use of different salts which we get in market like white, pink salt, does it trigger thyroid issues? If so, which one is safe to use?
So 100% we say that salts always Saindalona is the best, no doubt about that. And now one more thing that even modern people agree, we all are using iodized salts, everybody 100%, not 100%. Some people who are conscious about Ayurveda, like in my home, we use Saindalona only since many years. So we should have that presence of mind that iodized salt is not required for everybody. It is given to be only people who are at the risk of iodine deficiency in the environment, and they are having that chance of depletion. Only such patients should be given. But government will never listen to that, and they will always listen to the modern researchers. They say that iodized salt should be made compulsory and mandatory for everyone. And excuse me again if I'm using this word, I call iodized salt as Savisha Samudra Lavana. Iodized salt, I name it as Savisha Samudra Lavana because iodine is a toxic material also. And if you see these halogens, iodine, chlorine, bromine, fluorine, chlorine, when it is added to the water, you tend to lose the hair color. First, it will be black to brown, brown to gray. And I can say with a confidence that the number of hypothyroidism cases are increasing also because of unnecessary. We are feeding all the 3 times iodine every day, all the 3 times to our kids. Every day, all the 3 times we are feeding iodine, iodine, iodine. हम ये नहीं सोच रहे हैं कि आयोडीन की उनको जरूरत है कि नहीं है. इट्स इन नैनोग्राम्स इट्स नीडेड. एंड एवरी डे आर फीडिंग मीन्स, you please don't believe me, just Google about the toxic effects of excessive iodine to kids and other issues. So definitely you'll find. So what I say is pink salt, that is the rock salt, Saindolona, will be the salt of choice in our daily food. If you're sure that your area there is iodine deficiency, you can give iodized salt, but logically, wisely, not every day, but sometimes in a week, because डेली रिक्वायर्ड डोसेस कितना है आयोडीन का? बहुत कम है, बहुत कम है.
Okay, thank you, sir. Sir, we have one more question. How to understand that Virechin is good for conditions like infertility or PCOS associated infertility? When we correlate it with Vataj Gulma, which says na pakam upayati, how to understand involvement of pitta here?
Here I never said there is a role of pitta. And if they're asking the question because of Virechana, where directly it is told Virechana is just for pitta. Tat sthanagate sleshma, pitta sthanagata sleshma, and I said kapha. And Virechana is second best for vata. Vatasya Upakrama, Sneha, Sveda, Samshodhana Mrudu. There is nothing called as Samshodhana of Mrudu Vamana. There is nothing. There is Mrudu Virechana, my friend. So my concept of giving Virechana is for second best. Pittara first best. Second best for Tat Sthanagata Sleshma and Vayu. So my concept of entire hypothyroidism and PCOD was Vata Kafara. That's why I said Virechana. Not for Vamana, not for Pitta.
Okay. So they are requesting for dose of each ingredients like Dashmul, Kvat, Apamarga Kshar, Sarkshap Tail to make lep.
नहीं नहीं, लेप नहीं है ये। हाँ, अच्छा, तैल का लेप करना है तो इट्स फाइन. Please contact your HOD of Rashastra, they will tell you. It is the classical Sneha Kalpana mentioned in Ayurveda. The ratio of oil, Dashmulakwatha, and Kalka should be as per the classical method of Sneha Kalpana. That's it. And we prepared it in our pharmacy by the help of our head of the department, Dr. K. Patil, and other departmental faculty. And we have this in our pharmacy. We have kept it here. We have named it as Dashmulak Sharataila. हमने अपना own नाम दिया है.
So one more question. How long to keep the lap?
No, no, it's just oil to apply. It's not like keeping it on. It just apply the oil. It will be absorbed automatically. सरसों पे कल का लेप करना है तो until it gets dry by itself. Okay, we are not discussing about sarshap kalka. I'm talking about sarshap taila. It's oil base. So you can just apply and leave it. No need to remove it. You can apply and leave it.
Okay. Thank
Okay.
you, sir.
Yeah, welcome, ma'am.
As we have no more questions in chat box.
Hello. Hello.
Yes.
Myself, Dr. Smita Patil. I just wanted to share some of my experience. And also
Yes,
want to
Smita.
ask a question. Yeah. First of all, I'm very happy to see Sanjay Kadlimatti sir on this platform because as a Kelly alumni, student of Kelly, so when we are in first year, like we just took admission for first year BMS, that time also sir has took a lecture where he has inspired us with so many examples of Ayurveda and what potential Ayurveda has. So he has inspired us on the day one of BMS, the day one, first day of the BMS. So I just reminded those days. And now after completing the BMS, doing PG and practicing gynecology in Ayurveda, today it felt like today sir again encouraged me that there is a lot of potential in practicing Ayurvedic gynecology. So thank you so much, sir. And my question is, throw some light over like Shatapushpa Shatavari Kalpa explained by Kashyapa. So how we can use and till what dose and how many days in what conditions like Shatapushpa Shatavari Kalpa. Thank you.
Okay. It gives me immense pleasure that students remember me because I left KL in 2013. And to be very frank, I'm sorry, I don't remember your face, Dr. Smita, but still.
Because, sir, I'm a 2012 batch student.
Yeah, I left KL in 2013. So you're in
Ah,
first year at that time, I know.
yes, sir, yes, sir.
Okay. So Mansa's classmate or?
Yes, sir. Mansa's classmate.
Yeah,
Yes.
Mansa is my student. She has completed PG here only, and she is a faculty in our college only now, Kaya Chikitsa. So,
Yes, sir.
anyways, to be very frank, I have never used Shatapushpa Shatavari Kalpa. No experience regarding that. If any senior gynecologist present in this webinar, if they have any experience, I request them to share because it will be a learning for me also. But I have never used Shatavari Shatapushpa Kalka or Kalpa in my clinical practice. If anybody, please throw some light so that I can also start using it.
I think we have no response.
Yeah, no issues, no problem.
Yes, sir. Anyone else wants to ask some question? I request delegates to ask question. Okay, no more questions, sir. Thank you, sir. Thank you for this wonderful session. Now moving towards vote of thanks. On behalf of NEMA OBGY Society, I would like to express my gratitude to NEMA OBGY Society Central Office Bearers, Dr. Kamini Diman ma'am, Dr. Prajakta Nakade ma'am, Dr. Vishnu Bhavne sir, and Dr. Rajesh Utane sir for their guidance and support to conduct today's webinar. I would also like to thank and extend my gratitude to our eminent speaker, Dr. Sanjay Kadamali sir, who has enlightened us with the knowledge valuable and wonderful session. Thank you, sir, for the efforts taken by you.
very much.
I would also like to thank Dr. Prajakta Patil ma'am and Mr. Akash for their technical support. It was great working with you. Last but not least, I would like to thank all the delegates from bottom of my heart for their participation who made this webinar possible and successful. Thank you to all attending. Hope you all have gained immense knowledge from today's webinar. Wishing a wonderful evening ahead. Now, with due permission of all dignitaries, I would conclude today's webinar. Thank you and good night.
Yeah. Thank you. Thank you,
you
sir.
very much.
Thank you so much. Yeah.
Thank you, ma'am.
Thank you, sir.